Okay, let's start. Good evening, everyone, and thank you very much for joining us tonight. My name is Isabelle Lefebvre-Vary, and I am the co-founder and executive director of Fertility France Foundation. For those of you who don't know us, we are a Canadian charitable organization that offers grants to cover expenses associated with fertility treatments, IVF that can include egg and sperm donation, and gestational surrogacy. I'm happy to share with you that our grant application platform will be open starting next week on April 1st, and it's going to stay open for a month, so until April 30th. During that time, you'll be able to apply for one of our grants if needed. Tonight's session is part of Your Fertility Guide webinar series, which is proudly presented by EMD Serono. Thank you very much to EMD Serono for sponsoring the series. It's designed to provide accessible, expert-led education on key topics in fertility so that individuals can make informed decisions throughout their journey. However, Dr. Leonardi is not compensated for this webinar by FFF or EMD Serono. We thank him very much for his time and for sharing his knowledge with us tonight. That's actually the perfect transition because it's time for me to introduce you, Dr. Leonardi. It's a pleasure to welcome you tonight at tonight's speaker. Dr. Leonardi is an advanced gynecological surgeon and ultrasound specialist at McMaster University Medical Center and an associate professor at McMaster University. He is internationally recognized as a leading expert in endometriosis with a unique approach that combines advanced surgical expertise with high-level imaging to better diagnose and manage the condition. He has published extensively, presented at major international conferences, and is actively involved in shaping the future of endometriosis care through research, clinical guidelines, and global collaborations. We are incredibly grateful to have him with us tonight to speak on a topic that affects so many in our community. So tonight's webinar is Endometriosis and Fertility Beyond the Basics. Dr. Leonardi, thank you again so much for being here with us tonight, and I'll let you introduce yourself.
Thank you, Isabel. Thank you to all of you who are here today, and all of you who may watch this on YouTube or on other platforms after the fact to learn more about endometriosis and how it impacts fertility. I wanted to do this because I know how complex this subject is, and sometimes how limited we as clinicians can be in the clinical setting to be able to answer all of the questions that exist around this very complicated disease and its downstream impacts. And I know that there are lots and lots of questions that people leave appointments with, hoping to get answers, probably turning to resources online, very likely these days to large language models like ChatGPT or Gemini, for example. And I just wanted to be able to provide a voice to answer some of these complexities in a way that's easy to understand and hopefully useful to individual journeys, but on a larger scale to the fertility community, which is really important to me, even though I'm not a fertility doctor myself. I am an advanced gynecologist. I mostly manage patients from the perspective of diagnosis and symptom management, but I receive numerous referrals from fertility doctors in my community locally, and also actually from the broader sense in Ontario, from as far as Ottawa and Thunder Bay, for example, and Windsor. And so I do have a large role in contributing to the care of fertility patients. Sometimes it's more diagnostic focused, and sometimes it's more therapeutic focused, meaning offering my surgical expertise in those cases. I do have multiple different worlds that I live in. As Isabel said, I work at McMaster University where I have my surgical practice. This is where we see our consultations, and we offer surgical care for patients and long-term care as well when needed. And then I also have the ultrasound clinic, specialized ultrasound in gynecology and obstetrics, SUGO for short, SUGO. And that's where we offer more of a diagnostic lens to patients at the recommendation of their fertility specialists or their allied healthcare professionals that they may be working with through their fertility journey. And at that location, it's without necessarily a full consultation. Of course, we do absorb some information from patients to understand the context to provide a more clear diagnosis, but not management plan and not surgical plan. And then I think many of you also know that I have a large presence in research and working very closely with some of the fertility specialists in the province and beyond on research projects, and also working on endometriosis research beyond fertility as well. Everything from the assessment of patients, their preferences through that sort of diagnostic journey, all the way through to treatment related matters. And then I do lots and lots of advocacy and education. And if you're not already aware, you can follow me on Instagram or on TikTok, where I try and put educational content for both patients and also healthcare providers, trying to teach the wide range of individuals in this space. Today, I decided that I didn't really want to deliver a PowerPoint presentation because it can feel sometimes a bit too didactic and a little bit dry. And I know that many of you have individual questions and concerns that you're hoping to have answered. I think it's really important to say upfront that this is not a consultation, this is not an appointment. There's no ability for me to give you medical advice in this particular setting. And thereafter, people listening to this on YouTube should not take what I say as medical advice, but rather general principles can be gathered from the answers to the questions that I will provide today. I have some important themes that I'd like to touch upon, but I reckon that those will likely come out in some of the questions that have already been submitted and potentially some of the questions that may come up spontaneously today. So I thought that that might be a more engaging and an interesting way of providing that education to you all.
Thank you very much. I agree. It's always amazing when there is some interaction, and thank you for offering it. Maybe I can start with one of the questions that we already received. It is a broad one, so maybe it will allow you to touch upon some topics that you wanted to discuss tonight. So I'll start with the question. What can you tell us about silent endo and implantation impacts? How to support?
Great question. So let's talk about silent endometriosis first. What does that mean? Endometriosis is known to be a disease that generates a lot of symptoms for patients. Generally speaking, very severe period pain, pain outside of periods, including with ovulation, with bowel movements, with urination, with intercourse, just with being alone. That is what most of the time endometriosis is known as doing. But there is a small subset of individuals who have endometriosis, but either do not exhibit symptoms or maybe are not exactly bothered by their symptoms. I often wonder when I do identify endometriosis in people who say that they have no symptoms or they're sent for fertility assessment. I dig in a little bit deeper and I say, are your periods really 0 out of 10 pain? Are your, bowel movements really not problematic at all? Or are you just managing to live with them because you have learned how to do that? You've discovered your strategies that help with the inconveniences, let's say, in this particular case, because it may not be considered problematic from your quality of life, whereby you're missing work or school or social events, but you've learned how to handle it. And often what I hear in response to that is actually, yes, like I am bothered by them, but I know how to overcome those bothersome issues. I have figured out my strategies. So then I come back to the question of, is it truly silent? Or is it just that this individual person has learned how to manage those symptoms? But there is still a very strong likelihood that there are some people who exist in the world without having any real bothersome issues and have endometriosis. And so then we come to the question of, can that silent endometriosis impact on fertility? The question specifically was around implantation, I believe.
Yeah.
I'm going to take this broader as a concept first. So, from a fertility perspective, there are quite a number of checkpoints that need to be achieved to ultimately achieve the goal of live birth. Uh, the first, of course, is you have to have functioning ovaries, which will produce an egg and ovulate properly that egg on a relatively regular basis. You have to then have a sperm source. And in general, for most patients who are cisgender female with male partners having intercourse, that sperm source needs to be timed properly to the ovulation. There needs to be functional fallopian tubes where the egg and the sperm can meet. There needs to be an appropriately developed, without any intracavitary pathology, meaning polyps, fibroids, adhesions, infections inside of the uterus cavity. The endometrium itself needs to be receptive to the fertilized embryo. And then, of course, it needs to continue onwards. It needs to develop into a fetus and then eventually go on to a delivery. Endometriosis has an ability to impact every single aspect of the fertility checkpoints. It is thought, though not yet entirely clear, that the actual implantation is the least affected point in that fertility journey that endometriosis has an ability to affect. But there is still a belief that it can. And endometriosis, through research studies, has been associated to recurrent miscarriage. So, yes, there is an ability for that implantation to be problematic in a patient with endometriosis. The question is it a problem with the endometrium where the implantation is taking place itself, or is it a problem with the original egg source, which could have been affected by the inflammatory aspect of endometriosis on it, uh, decreasing the quality of it? Is it a problem with the overall environment of the pelvis from an inflammation perspective? We don't know the answer to that in an individual person, and even more academically speaking, we don't quite have the answer to why does miscarriage happen in somebody with endometriosis. But if you break it down to those checkpoints and you think about all of the places where endometriosis can impact a patient trying to conceive a pregnancy, then it makes a lot of sense that endometriosis can disrupt multiple points in that pathway. This could be a good opportunity as well to inform you all that endometriosis often occurs in the context of other gynecologic problems as well. It is a disease that has a really high association to adenomyosis. Adenomyosis is what I call the ugly cousin of endometriosis. From a cellular standpoint, there is a similarity where it's the improper placement of endometrial-like tissue cells. In the case of adenomyosis, this is within the uterus itself, in the body of the uterus, and endometriosis is on the uterus, on the surface, or anywhere else beyond in the pelvis. Adenomyosis can occur commonly with endometriosis and can be an independent factor in the issues that a patient with infertility or, for example, recurrent implantation failure or recurrent miscarriage is experiencing. And that really is an important disease to think of very actively in the evaluation process when people are going through their fertility clinic journey.
Thank you. But actually, I have a follow-up question, which I think is really related to what you said from another person who sent it before. I have a 2.5 centimeter endometrioma found on MRI, no significant symptoms, and a history of 2 miscarriages. My doctor says endometriosis affects fertility but not miscarriage, and excision specialist in Alberta declined referral. Could this endometrioma be contributed to my losses? And the subsequent question is there any way to see you as a doctor? I'm from Edmonton, Alberta.
Thank you for the question. I'll answer the second part first. And unfortunately, it's a bit too difficult for me to manage the demand of patients within Ontario, let alone outside of Ontario. And the same goes for my direct colleagues at our institution at McMaster University. The demand for endometriosis care is obviously very high and simply unsustainable, even locally. We're trying very hard to increase our resources within our team, to grow our team, to be able to provide more care. But we have had to, unfortunately, not allow out of province care anymore. The first part of that question is obviously going to be contentious because you've had a discussion with a doctor in your province already and have had advice. I'm going to again try and take this back at a more broad level because I cannot speak directly to an individual's medical experiences for many reasons, but in particular because in my opinion the necessity of evaluation for any patient with, well, probably any disease truly, but endometriosis especially, is a really nuanced one. We take a history that is multiple pages in length, looking at so many different factors that a person experiences. We take all these, let's call them data points or patient factors, and we put them all together to try and make our best clinical decision. And it's simply impossible in the context of a webinar or on an Instagram post to answer clinical questions because that nuance is missing. I don't have the nuance. But endometriosis and endometrioma, regardless again of whether somebody is experiencing bad symptoms from it, can be a cause of miscarriage, recurrent miscarriage. This is published. It is something that I have seen in my practice where we have patients who are experiencing various forms of endometriosis, have this situation of infertility, or have issues of recurrent implantation failure or loss. And depending on the circumstances, we may offer surgery that then allows for them to either try natural conception thereafter if other factors such as the uterus, the ovaries, and the fallopian tubes and the sperm source are all okay, are all in check. And also, to be honest, there is an appropriateness of age because age is a major factor in all of this as well. I have more recently had a patient that had frozen embryos and had failure of embryo transfer. We operated on her endometriosis, and then she did another embryo transfer, and it was successful. So, I mean, this is not a randomized control study. If if that patient had tried to put the embryo in without the surgery, there is still statistically a chance that it could have been successful without the surgery. And so this is an anecdotal experience of mine. But the point is, you have to take all of the factors. In this patient, this was sort of the last option to consider. Instead of trying again the same thing that had happened several times before, we tried something else in their experience, and that fortunately for them worked. But it may not have. And then, this anecdotal story may have leaned me more to suggest, maybe surgery is not the right answer. The point is, there is a potential utility of surgery in patients who have recurrent miscarriage from endometriosis, but there's other points in that patient story that are relevant that might have been influencing that doctor's discussion as well, that need to be accounted for on occasion.
Thank you. Another question. And maybe I'll change it a little bit because you answered part of it with what you just said. I have low AMH and endometriomas and deep infiltrating, finally diagnosed by you. Congratulations. And I have done 2 rounds of IVF, resulting in only one untested embryo due to low retrieval rates because of the endometriomas blocking access to my ovaries. Would it be reasonable to consider next step surgery as a next step? Sorry. And what questions would you suggest I ask my endosurgeon during my upcoming consult?
Great question. Again, this is not specific medical advice. I think the question that first comes to my mind is the low reserve, the low AMH factor of the endometriosis, or is it other factors, including age, as the primary reason why people's egg reserve declines with time? If there is a thought that there is a correctability to a degree with respect to surgery, then it may be possible to consider that. But the known um, data would suggest that cystectomy, removal of an ovarian cyst in the context of endometriosis, generally doesn't help the egg reserve. In fact, it generally harms the egg reserve. What it might do, depending on the size of the endometrioma and the extensiveness of the surgery, if there is still a good amount of ovary remaining at the conclusion of the surgery, it may help quality of the egg rather than quantity. And so I think that's the dialogue that needs to happen in these cases is if surgery is done, what is the risk to my ovary in terms of the quantity of the ovary? Because inevitably, when we take out an endometrioma, we have to cut through the ovary, which does destroy some ovarian tissue. The larger the endometriomas, the more the ovary is stretched out like a balloon, and the harder it is to maintain normal ovarian tissue through that excision of the endometrioma process. I think another relevant question for the endometriosis surgeon would be what other locations of endometriosis are present. And obviously, you've had an advanced ultrasound, so you would have had the mapping. So that would permit really nuanced dialogue of what is done at the surgery as well. Our goal in general with surgery is to do the best surgery for the patient a singular time, but sometimes that surgery may involve, particularly in fertility patients, intentional leaving behind of some endometriosis lesions to hasten the wait time for the surgery. In particular, when we do our cases with our colorectal surgeons, we do have longer wait times because of the complexity of the case, the length of the case. And so sometimes we actively decide to leave behind bowel endometriosis simply to get people in to try and make the ovaries healthier, in quotations, more accessible potentially to an IVF retrieval. So we do have these conversations where we're trying to balance the benefits and the risks and optimize from a timing standpoint as well. So I think those are some of the details that a conversation should include.
Thank you. I'll start with the question that we received live tonight. And I'll start with the first one. We'll go through them all, if that's okay with you. Is continuing to take Dynogest, after endoexcision surgery beneficial from your experience?
I'll answer this from the research experience rather than from my own anecdotal experience. The answer is yes, it is beneficial. There is evidence to support the use of post-operative hormonally suppressive agents, including Dienogest, to reduce estrogen, to reduce the likelihood of resurgence of endometriosis tissue. It's potentially beneficial for two things. One is for symptoms, maintenance of symptoms that may come from, again, other aspects of the pelvis that are generating of symptoms. So let's say you have excision of endometriosis, but then you don't have a medication where you're suppressing menstruation. Menstruation, in many cases, even in people who don't have endometriosis, is a pain generating process. It's an inflammation generating process. So by having that inflammation generating process happen, the nervous system, which has been exposed to long-standing inflammation secondary to endometriosis and potentially other things, is again going to be stimulated and a reminder of the pain that was once present. I would really, really encourage anybody in this, audience today or future audiences to delve more into the concept of pain science, the sensitization of the peripheral and central nervous systems from long-standing exposure to endometriosis inflammation, Because if you take away the endo, but you still have inflammation sources, that nervous system is still going to be responsive in a way that the threshold is lower, the pain is going to be higher. So it's beneficial from a symptom maintenance perspective, but very, very likely, although the evidence is a bit weaker on this, it Dianogest or other agents intend to reduce estrogen, the estrogen production from the ovaries, which is the main stimulant of endometriosis tissue. And if we think about endometriosis like a cancer for a second, I'm a surgeon, I believe I'm a good surgeon, but endometriosis tissue starts off as invisible. It starts off as cells, which we do not see, and then it grows into lesions, which is when we see them. At the time of surgery, just like in cancer surgery, there may be cells present that are invisible to us. They could be at the periphery of where a lesion existed. They could be in a location that is completely invisible to us and not near any current location that we're actively excising. So those cells could be present in a way that we don't know. And if we let them respond to the natural production of estrogen and the natural menstrual cycle hormonal patterns thereafter, then we may be at risk of those lesions going from cells, which we can't see, to something more than cells, and therefore having a more negative impact on that patient downstream.
Thank you. Actually, another question on Dianogest. Do you think taking Dianogest is beneficial prior to egg retrieval?
I'm not so sure I'm the best person to answer optimization of egg retrieval questions, as I don't do them myself and I don't often guide people through the process of them. But I think I would extrapolate that somebody, a fertility doctor, may be suggesting this because a patient has an endometrioma or has endometriosis, which is generating inflammation. And in the context of an endometrioma, maybe generating an actual size of an endometrioma that could make it more difficult for the purposes of retrieval of the ultimate oocytes that are generated. So there are some really logical reasons for doing this, bringing that inflammation down, making an endometrioma smaller potentially, which could help with the magnitude of the inflammation, but could also help mechanically for the fertility doctor to make a better oocyte retrieval. So in general, I think that there are some advantages. Are there any disadvantages to doing it? Again, I'm probably not the exact best person to answer this, but you want to talk to your fertility doctor about the duration of time between stopping Dianogest and, for example, an embryo transfer, where you're thinking about the endometrium, which the Dianogest will also thin. It will suppress the endometrium. So you want to think about, well, what could be happening with Dianogest that needs to be undone, and how much time do we need between stopping it and whatever that next step is.
Thank you. Have you found people who had symptom relief when taking natural anti-inflammatory supplements such as cerathiopeptidase?
I have no experience with this, I'm sorry.
Next question. Doctors say some people with endo are asymptomatic, yet my referrals have been declined numerous times because ultrasounds are showing up normal and my symptoms are not considered urgent. Additionally, I've been trying to get pregnant for years with no success. What options do I have to get a diagnosis?
So first, I'm really sorry that the health system is in existence in this way, where it's proving difficult to get care that you clearly need and desire and deserve. Um, we tried very, very hard at Sugo and through McMaster to never let a normal ultrasound to invalidate a patient's symptoms or their experiences. On the flip side, we also try to use the result of a normal ultrasound to inform patients about the positives as well. Um, when a scan is normal, and particularly when an advanced scan is normal, that's done by an expert like myself or my team members or those that I've trained across the province, We know that this tells us the likelihood of there being adenomyosis, PCOS, fibroids, polyps, deep endometriosis, adhesions, fallopian tube pathology. I know I said those very fast, but intentionally so because it's a very long list of this is good, this is good, this is good. There's a lot of good news in there. Doesn't mean that people who have a normal scan are not feeling stuff that is really bothersome and disruptive, but there's a two sides to the coin of good news and there's still maybe some mysteries there. When a scan is normal, and especially if it's an advanced scan, an MRI is not generally going to help find something because what the advanced scans have the capacity to do now is rule out deep endometriosis, endometriomas, and again, all those other pathologies that I've just listed. Superficial endometriosis is the one type of endometriosis that we cannot rule out. And we are very, very clear in all of our reports to say that, and that could be present. So the question of diagnosis then becomes, is it necessary to know with 100% certainty that it is there or not? And I think that this is a very individualized question and sequential answer. For some people, they're very okay with living with a degree of uncertainty around is there superficial endometriosis or is there not, when they know that all the other things are okay. And when that's the case, you can implement treatment options that are medical options or complementary and alternative options without knowing with 100% certainty. And every international guideline in Canada, in the United States, in Europe, in Australia, all of the guidelines tell us that we don't need to see endometriosis to initiate treatments for a presumptive diagnosis of endometriosis. I'm in total agreement with that, but I do think that it's so key to rule out the other things because if somebody has endometriosis and their ureter is blocked, I don't want to be just treating this patient with a medication. I mean, maybe they would be okay with it symptomatically, but their kidney is at risk of being lost from it. So I think an advanced ultrasound is necessary, but I do think that when everything else has been ruled out and the presumptive diagnosis is superficial endometriosis, treatments can be initiated by people. I think we probably have to have everybody stay off camera, if that's okay.
Yeah. Thank you. Yep. You want to
And
add?
I just wanted to say, I think the challenge with getting a referral is really difficult because honestly, every OBGYN in the province has a very long wait time and has, an overwhelming demand and limited resources and time to be able to see patients regularly and see lots of patients. So I know that this is a common challenge. I would do as best as possible to start some treatment options, considerations with the primary care doctor, and really try to find one of the doctors who is within the endometriosis space by using the Endometriosis Network Canada as a resource and use that as a place to identify potential options for referral. And you have to just keep persisting. That's the reality, unfortunately.
Thank you. How accurate is endomapping in identifying the location and stage of someone's endometriosis?
Very accurate, but it has to be done by somebody who is very well trained.
Mhm.
So the thing about endomapping, either through ultrasound or through MRI, the technique matters. With ultrasound, you have to know what structures to look at, how to do dynamic maneuvers. With MRI, it's often a bit more about the protocol that's implemented, which series are obtained, whether there's contrast or no contrast, for example. So there is the technical aspect, but it's ultimately the eyes of the doctor on the images that has to be strong. They have to be well trained to know what is normal and what is abnormal. In the introduction of advanced imaging techniques through the province, through Ontario, through Canada, and beyond, it is likely that we will see people who are in the process of becoming experts or are saying they're experts, but they're not experts. It's very, I would say, trendy, and it's definitely justified that this is something that people want and should be doing because we need more and more advanced techniques in imaging coming forward. But it is possible that at the beginning, if that expertise is not there, we could have false positive diagnoses, meaning somebody has a scan that finds something that's not actually true. And what we have measured is a lymph node or a vessel and not a nodule, for example. And then the opposite is definitely true as well, where one might just miss an endometriosis lesion altogether. So the accuracy is going to depend on the person, the team doing it. But in the hands of those who are experts, and this is again evidence-based published literature, very, very accurate for our ability to rule in the disease and rule out deep endometriosis. Um, Superficial endometriosis, as I said earlier, remains the most enigmatic or hidden type of endometriosis. These lesions can be less than 1 millimeter in size, so very, very small, very difficult to see. And so those lesions are the most at risk of being missed, if you will, on a scan. Uh, but again, we're very clear in our reports to say that we cannot rule out superficial endometriosis at this particular point in time with any imaging test.
Thank you. What are the pros and cons of excision versus ablation surgery to remove endo?
Great question. It is thought, broadly speaking, amongst the endometriosis surgical and academic community that there probably is not a large role anymore for ablation techniques, and excision techniques are preferable as lesions have an infiltrative nature, uh, whereby if the surface only is disrupted by energy, either laser or cautery, for example, it may be insufficient to encompass the entire lesion removal or destruction. So I would say most people who are doing endometriosis surgery are what we'd call excision surgeons. But the reality is that some locations are actually still requiring some degree of ablation. So if, for example, you have an endometriosis deposit on the back of the uterus, it's very difficult to cut into the uterus with a depth of cut because the uterus is an incredibly vascular structure. It has a lot of blood flow to it, and it can be very, very bleedy. And usually these types of lesions are not that deep in their infiltration. That would actually make them adenomyosis if they become more infiltrative. But if they're just simply on the surface, it is thought that those could be more amenable to a burning technique or a laser technique. And the same would go for lesions on the surface of the ovaries, which again are vascular structures and incredibly important, particularly to the audience today. If we cut into an ovary to try and remove a 1 millimeter lesion, we will end up removing some ovarian cortex, which on balance may be the worse of the two situations. But I would say, broadly speaking, ablation is not really used, except for in a few very subtle instances where the benefit the risk of cutting into that structure outweighs the risk of the ablation technique.
Thank you. After 4 miscarriages, I was diagnosed with endometriosis and just had successful excision surgeries 3 weeks ago. Congratulations. Eager to try to conceive again, but fearful inflammation, etc., may remain. What do you suggest post-op for best fertility outcomes?
So again, it's not possible to make true clinical recommendations, but the former question that we talked about around the use of hormonal medications postoperatively is relevant here. Certainly, the implementation, the use of a medication like Dianogest or combined oral contraceptive pill or a GnRH analog, anything really that really makes the estrogen decrease to decrease the stimulation of endometriosis tissue is likely to be useful. However, some people who are post-op with a desire for fertility actually endeavor, they aim to conceive right away. And that's actually kind of a good time to try when the endometriosis tissue is just recently removed. It's likely that the burden or the quantity of endometriosis tissue in the body is way, way, way less, hopefully zero, but way less. And so if somebody is aiming to try and conceive very quickly after surgery, then we usually don't start people on hormonal medications. We say just, as soon as you're feeling well enough, let's go, get back to trying to actively conceive. But you want to be mindful that the longer that period of time is without any suppression of the estrogen and therefore the potential stimulation of endometriosis, that could be problematic. So I generally tell people go and try for somewhere between 3 to 6 months, up to you. Work with your fertility team to have a plan B ready to go. So if the natural conception doesn't work within a predefined amount of time, have your plan ready so that way you're not wasting. It's not so much about time per se in the sense of, fertility and time is kind of counter to each other. It's more the amount of time where the ovaries and the uterus are permitted to exist in their natural state, which is generally, and again, remember, I help people with severe pain, generally not going to be so helpful for their pain journey. And we really want to be able to reduce that pain experience by reducing those pain generators so as to also diminish the long-term impact on that nervous system that's kind of constantly being bombarded by inflammation.
Actually, a follow-up question. Could the IVF process cause endometriosis to worsen or return after excision surgery has been completed?
This one is a really tough one. I'm not sure I'm entirely familiar with the literature on this to answer with full confidence. Uh, I believe that it has not been shown that the IVF process would worsen endometriosis. Um, and it's not clear that it would necessarily be the cause of the recurrence of endometriosis. Um, with respect to endometriosis progression in general, it is thought that it is a progressive disease. Of course, people are not born with it, and people do not have endometriosis usually, at a very young age as an infant or as a child. It probably is a disease that initiates around the early years of reproductive function when periods initiate. And it is thought to be progressive to eventually form these cysts, which contain blood, and to form deep nodules in structures like the bowel or the ligaments or the bladder. Those are not there from day one.
Mm.
But some of the literature would tell us that endometriosis probably has an increase and then a plateau whereby at a certain age, and the rough estimate is around sort of the late 20s, early 30s, where we don't see lesions getting worse or more lesions coming up. We sort of see a more stagnant endometriosis state. And so sometimes there are coincidences. So somebody may be in an age range where their endometriosis is on its own progressive and IVF is done, which may then make it seem like IVF is the reason for that. But it may be coincidence instead of causation in some cases. But as far as I have seen in the literature, it's not thought that IVF worsens or results in a recurrence.
Thank you. Another question, and I'll read the entire question, but I think you just answered the second part of it. I had 2 rounds of egg freezing, retrieved total 9 eggs in 2 cycles. I had huge flare-ups during the egg cycles, especially the first one. Is this common for endo patients to respond to IVF, to poorly respond to IVF, or is this very personal? The second part of the question, is it possible to feed endo with more egg freezing cycles, which I think you just answered.
Yeah, the second part was just answered. With respect to flares of endometriosis or flares of pain, I think it's definitely always important to question what is this symptom from, broadly speaking? One of the really big downsides to endometriosis as a disease is that it is the scapegoat for lots of things. And in many cases, it is directly linked to an array of experiences and symptoms. So there is a likelihood that there is a connection there. But for example, if somebody is having an oocyte retrieval process, whereby they're injecting themselves with medications. They're having a very large growth of the ovaries with distension of the ovarian cortex, meaning stretching of the cortex, production of lots of pelvic fluid, and then ultimately somebody is doing an oocyte retrieval process where you have a needle stuck into your body to retrieve eggs. Forget about endometriosis for a second. There's lots of pain generating possibilities along that path that somebody, even without endometriosis, may experience. But if somebody has endometriosis in the background, whether silent or not silent, there is a likelihood of endometriosis having an influence on that nervous system, whereby that pain threshold changes again. And then any of these processes, which are sort of by nature uncomfortable or painful, are going to be interpreted by the body, in particular by the pain system, as worse, as more dramatic, more terrible, and then it's going to result in a flare. And so I think we have to always ask the question of, why is there a pain generator? And, what could be making that pain generator worse? Is the endometriosis in the background? It's probably not that endometriosis itself is being actively flared at that time, but it's also not impossible that endometriosis would be responsive to the high levels of estrogen in that moment of time and produce thereafter more inflammation.
Thank you. So tonight I've learned to pronounce a new word, which I'm going to pronounce a few times tonight, I have the impression. So if Dynogest, new word, washes out minerals and calcium from one's bones, what are the ways to protect the bones in the long term, if taking Dynogest for many years?
Mm. So, whenever we use medications long term that have a possibility of having downsides, such as bone density loss, we have to do a couple things. The first is that we have to monitor that. And this is, again, not perfectly evidence-based, but in our center, for those who are on long-term Dianogest successfully with respect to symptom management, we usually do a bone density test every 3 years to ensure that the bone density is maintained. Now, with Dianogest, it's thought that bone density should be maintained, but there is a slight risk that it may be impacted. So first and foremost, if there is an impact, then you decide whether you continue it or you don't continue it if there are alternatives. Uh, Dynagest is not thought to suppress estrogen to the same degree as some of the other medications, like, for example, the gonadotropin releasing analogs, antagonists and agonists. So we don't always add back estrogen with Dynagest because actually the goal with Dynagest is reduce estrogen. And so we don't always do that, but it's something that can be considered. Add back estrogen with Dynagest to help with that issue of bones. And then sometimes people switch agents. They switch to a different progestin. They switch to a combined oral contraceptive that contains a progestin like Dynagest and an estrogen to offset some of that bone issue. And then always general bone health is key. So dietary strategies for sure, supplementation with calcium and vitamin D, and weight-bearing exercises are really key as well.
Thank you. Not a fertility specific question, but I have seen two endo specialists. I do have bowel issues symptoms. They think my symptoms can be just IBS. I had endo mapping done at Mount Sinai Hospital around 4 years ago. Endometriomas found, and there were lesions on ovaries. Nothing came up about bladder or bowels. Is it still possible to have lesions on bowels, even though it was not found during that endo mapping?
So we've talked about this a little bit
Yeah.
already. We've talked about the potential for false positives and false negatives. I think the answer is yes. I mean, it is possible. Anything in medicine is possible. The one of the um, most frustrating parts about medicine is we can never say always or never. And so this is a possibility. However, it is not necessary to have endometriosis on the bowel or the bladder to have bowel or bladder symptoms, respectively. Endometriosis is a pelvic disease at its core, although of course it is can be outside of the pelvis in many patients and has symptom generation for sure that are non-pelvic. But the bowel and the bladder exist in the pelvis, very close in proximity to endometriosis that is in the pelvis. And endometriosis is an inflammation generating disease that then changes the nervous system of the body, but of the other organ systems in the pelvis. This is through a process called cross sensitization. And so we have many, many patients who have symptoms like IBS, although for what it's worth, IBS is a diagnosis of exclusion. And if you have endometriosis, then most likely the symptoms are not IBS, but endometriosis generated. But the cross sensitization process yields these bowel symptoms of urgency, of pain, discomfort, of irregularity in terms of the bowel habits. But it's not always endometriosis directly on the bowel. It can just be the endometriosis close in proximity that's changing the nervous system of the bowel, which then sounds very much like IBS. So it would be better to not have bowel endometriosis, that's for sure. And certainly, having operated on many, many patients with bowel endometriosis, bowel surgery does not always fix all those symptoms because it doesn't change the nervous system. What has to happen alongside any surgical treatment or alongside any medical treatment is when there is evolution, and generally speaking, and sort of a negative evolution of the nervous system to be overly responsive to stimuli, then we have to retrain that nervous system. We have to really actively work to retrain that nervous system to be able to undo those symptoms. It goes the same for bladder symptoms, urgency, frequency, feeling like you have to get up in the middle of the night. These are neural patterns that have developed with time, partly in secondary to endometriosis, but also, my body always wakes up, before my alarm to empty my bladder as well. That's a nervous system pattern that's generated over time. And then the body gets used to it. And then it follows that path of least resistance. So there is a way out of a lot of these symptoms. And it's often not medications or surgery. It's often really concerted effort to retrain the nervous system to not yield a lot of these responses to sensations.
Who can help with retraining the nervous system?
So this is most often not true doctors. Our team is very aware of it, and we guide people on it. But it's generally speaking pelvic floor physiotherapists and pain psychologists that work on the nervous system, work on the retraining of the nervous system. There are some others that can be really helpful. So we talk to they're experts in the muscle system, so that could be massage therapists or osteopathic practitioners. Acupuncturists can have a role in that retraining as well. Certainly, with respect to IBS, we would absolutely integrate a registered dietitian into the team because there are patterns of recognition of food patterns as well.
Mhm.
So that needs to be brought into it. I think many of you might be already aware of this, but I have established with the incredible expertise of pelvic floor physiotherapist Jill, pain psychologist Laura Katz, and registered dietitian Emily Arthur, Endometriosis 360, which is an interdisciplinary program that is meant to give people the tools to do this, to retrain the systems that have become unfortunately incorrectly trained with time, secondary to endometriosis, plus or minus other factors that are in people's lives that are contributing to those downstream nervous system pain system changes.
Thank you very much. I ask you the last question. I'm sorry for the question that we couldn't answer tonight. Like Dr. Leonardi couldn't answer, not me, but only him. So last question for you. Can surgical management of endometriosis negatively impact fertility outcomes?
Yes, it can. Surgical management absolutely can. This is one of the reasons why it is such a nuanced discussion in the office with my patients. I really, truly, truly wish that we had the snap your fingers surgery that would fix this problem of pain and fix this problem of infertility, and you'd go on and succeed in whatever the goal it is. But surgery can be very negative. In some hands, it might result in leaving disease behind if there's not a recognition of endometriosis there in the first place. So, one of my main messages that I want you all to take away with is if you are going to pursue a surgery for endometriosis, it is, in my opinion, mandatory to have an advanced pelvic ultrasound before the surgery. You need to know what you're consenting to. You need your surgeon needs to know what they're going to do, how long it's going to be, who they need to bring with them. Are they the right person to do this? Because endometriosis is not a simple disease to manage surgically. And if you have the wrong person who's ill prepared, sometimes from the lack of imaging preoperatively, then that might result in residual disease left behind. It could result in removal accidentally of an ovary. It's something that you have to be really cognizant of. Even in the best hands, even with the most preparation, though, you can still run into unfortunate events. Loss of ovarian tissue is one of the most real possibilities when endometriomas exist, when there are large endometriomas, in particular, because that ovarian tissue is so stretched out and so fragile in a way that sadly results in excessive loss of ovarian tissue. And so it's something that you really have to be sure is the right decision. Surgery is not an inconsequential or small thing to do. As a surgeon, I have, a desire in my life to never have surgery. We should, not necessarily aim for it if there are non-invasive alternatives or safer alternatives or potentially more evidence-based or efficacious alternatives, because surgery is something that is risky. It is consequential of the organs present. And for those that have pain as well, it is unfortunately in and of itself a pain generating event. And so it just adds a little bit of insult to already a nervous system, a pain system that has been insulted repeatedly by inflammation and pain. And so we really have to be delicate. And trust me, I operate a lot. So there are patients who are good candidates for it, but we have to be making sure that we're picking the right ones.
Thank you very much, Dr. Leonardi. If people have more questions or if they want to reach out to you, you mentioned that they should follow you on Instagram to get more educational content about endometriosis. Any other contact you'd like to share of your clinic that they could reach out to if they'd like to make an appointment with you?
So yeah, if you want to learn more in a relatively informal way, the social media platforms are sort of the key platforms right now where content is put out on Instagram and on YouTube primarily, LinkedIn as well. Just for what it's worth, I don't respond to DMs. I don't respond to personal questions in the comments around, what should I do in this situation? As I said at the beginning, there are platforms for proper medical advice. To be referred to my clinic, one needs a official referral form from a family doctor, from another gynecologist, and that referral form can be found at my website. There are long wait times, unfortunately, so that is a sad reality of the system that I am actively trying to work on optimizing, but that is a way that one can be referred. When a person is referred, there is no guarantee of acceptance. We do review the referrals to determine whether somebody is the right candidate for a visit with us. Particularly if you're coming from a region that is a bit more high density with respect to eligible, good quality colleagues. Usually, some of the bigger cities like Toronto and Ottawa are not cities that I am able to see people from because there are enough doctors in those local health networks that can, or at least, there are more. Maybe not enough is not the right word there. But yeah, that's it for me. I hope that this platform, I hope that this way of doing this was certainly more engaging. I definitely enjoy this much more than giving a talk. And if you want to watch a talk on endometriosis ultrasound, you can go to my YouTube channel and watch that there. But I hopefully this was a more lively way of doing this.
It was incredibly insightful and very informative. So thank you very much for doing that. Thank you to everyone who joined us tonight. And thank you all for your questions as well. We hope that it brought some guidance and clarity to you all. Thank you very much to EMD Serono for sponsoring your Fertility Guide webinar series. Again, as a reminder, our grant application platform opens next week if you're interested in applying to one of our grants. We also have our annual fundraiser, Night One, coming up on April 16. It's a dance party, so it's fun and it's an opportunity for the community to gather in an informal setting and have fun together, both industry, fertility doctors, nurses, specialist patients, anybody in the fertility world and beyond. Dr. Leonardi, you're very much welcome to attend. We'd love to have you there. And next webinar will be with Dr. Tom Hannam from Hannam Fertility, and he's going to talk about unexplained infertility and what's next when you've been diagnosed with unexplained infertility. Thank you again very much, Dr. Leonardi. It was a pleasure to have you, and have a very good night, everyone. Thank you.
Thank you. Good night, everyone.
Thank you. Bye-bye.